My name is Peter Fanner, and I'd like to welcome everyone here to the UIC Innovation Center for this event. We at the Innovation Center here, we bring different disciplines from around the university together to work on different projects. And one of our biggest departments here is urology. So urology at UIC is probably the most innovative department in the university. Craig, the department head, Niederberger, is won UIC Innovator of the Year once in the last couple of years. So urology is a big part of the activities here at the Innovation Center. We're currently working on a dedicated R&D lab for urology, and we have at least 20 urology projects running here at any one point, various different projects. And with that, I'd like to introduce Dr. Craig Niederberger, the Department Head of Urology.
Thank you, Peter. It is just such a delight to participate in the Drive for Men's Health. This is really a fantastic opportunity to bring attention to a really, really important area. And here at the University of Illinois at Chicago, we have an innovation center where technology meets health and meets men's health. So we thought that it would be a really nice opportunity to host this wonderful event at the University of Illinois Chicago Innovation Center. So thank you so much for the ability to do this, to contribute to this really important topic, and also to the sponsors for making this something that we can share with the world. So I'd like to talk a little bit about the perspective of men's health from reproduction and male fertility. So first, I'd like to talk about men's health. Men's health is just a huge problem, and it has a lot of attention. If you just do a Google search on men's health, you can see you get 217 million hits. So people are very, very interested in men's health, and it makes perfect sense. There's a whole month devoted to men's health, and that is November or Movember. This November, remember that because it's a really wonderful way to share in something that is so important and so impactful for global health. So what I'd like to talk a little bit about is male fertility, hormones, and men's health. And what I'd like to start out talking about is something that a lot of couples don't really consider until they're into trying to have kids and having a difficult time, and that is male fertility. So one of the things that couples don't appreciate, because everyone in high school is told how easy it is to have kids, is that it can be very, very difficult to have children. And it literally is a roll of the dice. Women are ovulating every month, and yet it takes about 6 months for a couple to conceive. The women are literally getting pregnant every month, but it only happens once where the little embryo implants. And the reason for this is that human reproduction is incredibly complicated, and it screws up 5 out of 6 times. And that's one of the things that is very useful to know when you're going in and trying to have children. So who's responsible if after 6 months, a year, 2 years, the couple still hasn't conceived? About half the time it's the woman, about half the time it's the guy, and about a third of the time it's shared between the two. So one of the things that I'd like to talk about is how hormones impact men's health in male reproduction. And it's very much like the thermostat and the heater in your room. So you have a thermostat, that's the pituitary, that's up in the brain, and you have the heater, that is the testes that make testosterone and also the sperm cells. And the thermostat literally sends electricity down to the heater in the form of a hormone called luteinizing hormone, or LH. In response, the heater heats up the room, and this in the body is testosterone. And interestingly enough, all men have a little bit of estradiol, the female hormone, and it turns out to be really important, just like all women have a little bit of testosterone, the male hormone, and it turns out to be really important there too. So it's the thermostat that sees estradiol that then says, okay, the room is hot enough, I'm going to turn down the electricity, or I'm going to turn down LH. And so all of this conspires to make a sperm, because you need very, very high levels of testosterone in the testis to make sperm. One of the really interesting things is that in a guy, it's estradiol that controls bone density. So estradiol turns out to be really, really important in the male. So the female hormone turns out to be super important in the male. One other thing to realize is that it's kind of like gasoline. You have this high octane component, and that's the bioavailable testosterone. That's the testosterone that the cells actually work on. So why are male hormones important? Well, first of all, 1/6 of all men have low testosterone. 1/3 of men with problems conceiving have low testosterone. And 1/2 of all guys who don't have sperm in the ejaculate, a condition we call azoospermia, have low testosterone. So low testosterone is really important in fertility, and it's really important for overall health. And it's also something that gets worse as men age. So men's testosterone decline with age. There are many studies which identify this. The Baltimore Longitudinal Study of Aging is a really good one. And it demonstrates that as testosterone levels fall, the high octane component falls even farther, because there is this protein called sex hormone binding globulin that literally takes testosterone out of circulation. So aging is associated with loss of testosterone and a lot of consequences. Problems with erections, problems with muscle loss, increased fat, osteoporosis, broken hips and back, loss of body hair, anemia, and memory loss, and others. Getting old sucks. So this is an example of something that that you can see in both men and women, and that is that fractures increase as people age. And everybody knows that after women go through menopause, osteoporosis is a really big problem, and broken hips and backs are a really big problem. But few people know that 10 years later, it's the same thing with guys, and it's the same problem. Hormones are declining, and so bones are getting weaker, and they're breaking more. So what can we do about this? Well, obviously, going back to that heater and that thermostat, we can just step in and give testosterone, and that's literally like bringing a space heater into the room. What that does is it signals to the pituitary the room is hot enough, and the pituitary says, yep, turns off its electricity, and sperm goes away. So actually, testosterone is a pretty decent contraceptive, but if a guy is past his reproductive years and wants a great therapy, testosterone can really do it. But what about a guy who is still interested in having kids and has low testosterone? And as you saw, there are a lot of those. So one of the things that we can do is we can put an ice pack on the thermostat. We can either give drugs like clomiphene or tamoxifen, which are used in women, and they block estradiol. Or we can give drugs like anastrozole or testolactone that are also used in women and in men, and they block the conversion of testosterone to estradiol. So if estradiol is too high, this is great therapy to increase testosterone and bring down estradiol at the same time. Or we could step in with just, putting some alligator clips on those wires that go from the thermostat down to the heater, and give something that's very, very similar to LH, and it's called human chorionic gonadotropin, or HCG, and it works quite well to just tell the heater to make more heat. So I'd like to end with just a couple of resources that you may be interested in. One is I do run a blog on male fertility called maledoc.com. And you can follow me at Twitter. This is my Twitter handle, Craig Nee. I'm also co-editor-in-chief of a journal that's devoted to fertility called Fertility and Sterility. It's been around for about 70 years or so, and has a lot of the advances in the field published within it. And you can go to fertsturt.org if you really want to drill down into what's happening in reproductive medicine. And we also have Twitter and Facebook feeds, as well as a YouTube feed, and so I would encourage you, if you're interested, to check out Fertility and Sterility as well. But mainly, I just want to say men's health is really important. Male reproductive health is often overlooked. It is just so wonderful to be able to focus on this here. I am so grateful for the opportunity. Thank you so much.
Thank you very much.
It is my extraordinary pleasure to introduce the next urologist who will talk about really important issues in men's health. His name is Ervin Kociancic, and he is truly a global leader in men's health. He is also the vice chair of the Department of Urology at the University of Illinois at Chicago, and is internationally known and is a leader of many international organizations in this area. And he's going to be talking about two very, very important aspects of men's health. One is prostatic enlargement and how that can affect health. And the other is erectile dysfunction or impotence and how important and common and how treatable that is. So welcome, Dr. Kociancic.
Thank you very much. So as Dr. Niederberger just said, we are going to talk about two main issues that every man can experience in his life. So having troubles in the bedroom and having troubles in the bathroom. Let's start with the bathroom first. One of the reasons why a man can have a problem with the urination is because of this small little gland which is called prostate. It's a small gland that used to grow with the aging, with the time. It surrounds the urethra, and that's why it causes all the problems in bladder emptying. The role of the prostate is actually very related to what Dr. Niederberger is doing with the fertility issue. So prostate produces part of the fluid that the semen needs during the fertilization process. So what happened with the aging? You have that. You can see this in the slide. The prostate gets bigger and bigger and bigger, and causes some severe issues onto the bladder emptying. So the bladder is made of, beside other things, of a muscle, which is actually not designed to work against the resistance. When I'm saying work against the resistance, is what we are doing in our gym. We do weightlifting because we want to have our biceps and our muscles nice and strong, but the bladder was not designed for this. And the weight for the bladder is represented by the prostate. Whenever we have the prostate, the bladder has to squeeze, and a large prostate, the bladder has to squeeze and is doing this extra exercise. And the bladder hates this. Bladder is it's a very lazy organ. It wants to be just doing the two simple things: store the urine without letting you know that you have this process going on in your body, and when it's time, just squeeze it smoothly out of your body. When you have a resistance, like an enlarged prostate, there the problems are starting. How common this problem is shown in this slide here. 38 million men are affected by, on a yearly basis, by enlarged prostate. We call this BPH. It's benign prostatic hyperplasia. Hyperplasia means that the prostate is getting bigger, and benign means that this is not secondary to a cancer, to a tumor in the prostate. And as you can see in the next following lines, the older we are getting, the more common this problem is becoming. So if you are in your 60s, you are 70% of your patients will have a problem like this. But if you are in your 80s, 90% of the patient will have this kind of problem. It's almost like saying that we were predisposed to have some problems with the prostate. Here is nicely shown how this process starts, and this process starts as early as in the 20s. So when you're 20, your prostate starts growing in time. This starts in the central part of your gland, and as the time is going by, you will have the whole prostate will become bigger and bigger and bigger. And this is on the bottom part of this picture. You will see how this enlargement of the prostate can basically make the the opening of the urethra closer. So that's why the bladder is fighting against this and has to work against this weight represented by the prostate. And trust me, the bladder hates this. Bladder, it's such a lazy organ, wants to work without any fatigue. So if you answer yes to any of these questions, this is what we are asking to the patients with a large prostate. How frequent you urinate? If you have to urinate frequently, you might have some problems with your prostate. If you have to go during the night time to empty your bladder more than once, you have some problems with your prostate. We call this nocturia. As I used to say to patients, night is usually for sleeping, especially if you're in your 80s. So if you have to go to urinate more often, you have to check your prostate. If you have a sudden urge to urinate, means that you have to leave whatever you're doing and go to urinate, means the bladder is becoming the guest star of your body. This is not good. Check. You have to your prostate and your bladder being checked. If you have pain with urination, if you have difficulty, if you have to strain a lot before you can start urinating, those are all signs of the prostate that is not behaving as it should. As the time progresses, your stream is going to become slower and slower until the prostate is going to win the battle against the bladder, and the bladder will no longer be able to empty. So we call this urinary retention. Retention means that you cannot, you retain all the urine that your kidneys are producing into the bladder. And the solution is now not only that you have to get up at night to urinate, you have to get up at night and go to the emergency room so that the catheter can be placed and we can emergency drain the bladder. So that's why the prostate has to be checked, and actually we have to treat this kind of functional problem. As I said before, this is not a cancer. You can live for 150 years with an enlarged prostate. The problem is the quality of your life is going to be miserable. And of the partners that is living with you is the same. So what are we doing? What can we do for these kind of problems? We have great medication for this. We are combining medications that are opening the bladder neck. We call those alpha blockers. It's just a difficult name because there are some cells into the bladder neck that are named alpha cells that can react to this medication, so opens the bladder neck. And we have another medication that shrinks down the prostate, which is called finasteride. That's the first one that we use. A combination of these therapies is the best option that we have for this. But when these treatments are not enough, we have to offer something more. We have to rescue the function of the bladder. And so we have intervention for this. We have surgery. On this slide you can see what the goal of our surgery should be. Make our channel bigger. And we can obtain this in several ways. We can go with an instrument inside and scrape out this part of the enlarged prostate. And we can do this with normal procedure. You will hear this name TURP, which stands for transurethral resection of the prostate. But we have more modern procedure, less invasive procedure than this nowadays. We can use a laser. With the laser, we put a small fiber into the prostate and we vaporize the prostate. So the prostate is basically melting in front of our eyes when we're doing this procedure. The advantage of this is that you have less bleeding, but it's still a long procedure. Nowadays, we have some very new minimal invasive procedure. I have here in my pocket the thing that we are using into these patients. I don't know if you can see it. I can barely see it, but this is exactly what we are using in our patients. Small anchors that we can place into the urethra, and through these anchors we are obtaining this opening of the channel. As you can see here in this animation, you can see anything because it's pulling me out. So with the procedure, we are basically placing the anchors into the prostatic urethra. The urethra is the tube that connects the bladder with the out of the body. And placing these anchors, we are basically trying to achieve the same effect as with the surgery, with the endoscopic surgery that we were doing before. Trying to achieve a big open channel, but without cutting down. So that's a really non-invasive procedure. This procedure has been, I've started doing this many years ago overseas, and it's the great news that it's now available in our country as well. So we can offer to our patients also here. And at UIC, we're actually the first one to start doing it in the big city of Chicago. So you no longer have, if you qualify for this procedure, you no longer have to stay in the hospital with the catheter, with the fluid running through your bladder to prevent the clotting. You can go home right after the procedure, and the procedure takes no longer than 10 minutes. Let's go now to the most serious disease that can affect the men in after the age of 40 or 50, which is erectile dysfunction. As you can see here, that what is the erectile dysfunction is the inability to achieve or maintain an erection, and or that this erection is not firm enough to have an intercourse. And as you can see here, there are two very scaring numbers. The one is the 30 million Americans suffer from this disease. This is a lot of patients having this problem, but this is not the one that scares the most. The one that scares me is that this process starts at age of 20. So there are basically kids in their 20 having problem with the erections. That's why it's good that we have that the science advanced and the art of medicine advanced so much that we can actually address these problems. How are we addressing these problems? We have great medications that we can use for these kind of patients, and those are very well known. I'm not going to mention any name, I just mention some colors. You have the blue pill, everybody knows what the blue pill is. You have a pink pill, you have several colors for this, and they're all doing great. Great because you just take this medication half an hour prior to your intercourse, and then if everything is still working, you can have your intercourse. Now the problem with this is that some of them are very expensive, and a lot of insurance plans are not covering them. But it is what it is. For the good thing in the life sentence, you have to pay a little bit more. When the medications are not working, we have other options. It's not that your medication is not working and now you have only a good book instead of having a good sexual intercourse. We can offer you something else. And this something else goes from very simple devices like the VED, which stands for a vacuum erection device, which is basically a hollow plastic tube that you put on the penis. You suck out the air, and this attracts the blood into your penis. Then you put a ring on the base of the penis, which allows this blood to stay into the penis, and you can have an intercourse. Now, I understand this is a great device. It's less expensive on the long term than medication, but takes away all the poetry of an intercourse, because this is a big piece of equipment that you need to have for your intercourses. There is something a little bit more invasive, less troublesome than this big vacuum device, are the injections in the penis. So if we can inject some drugs, some medications into the penis, and these are going to attract this blood into the penis and provide you a better erection. Again, this is, if the first one was not that poetic for intercourse, this is probably even less poetic. So when everything fails, we do have some great other options that are basically represented by a prosthetic surgery. And we use in medicine this prosthetic surgery for many couple of centuries, I would say. When an organ was failing, when a limb was failing, we would put a prosthesis, so something that is going to replace this organ. Well, we can do the same thing with the erectile dysfunction. We are now able to place a prosthesis within the penis, and that can be activated whenever this is needed. These prostheses are very well tolerated by the patients. As you can see here, you have several components of the prosthesis. Basically, we divide them in the one that are more natural looking, like the inflatable prosthesis. They're natural looking because you can deflate them and then nobody can say that you have a prosthesis. Or the one that are less natural looking, but easier to manageable, which is the malleable prosthesis. You have basically something into the penis that makes the penis rigid all the time. You just have then to bend the penis on the side to have the intercourse. The acceptability for these kind of implants from the patient is just fantastic. They love this. I remember I had this is a typical problem for patients after radical prostatectomy. So whenever you have cancer in your prostate and the prostate gets removed so that you can live longer, very often we are damaging the nerves that are controlling the prostate. And I remember a patient that I treated for an erectile dysfunction. He said, "I'm glad that I'm here, but now I feel like a dead tree." And we did this procedure, and he said, "I have now a new spring in my life." It changed completely the quality of the life of the patient. This is my very last slide, just to convince you that this, as our ancestors used to say, you better have a urologist as a friend, because as the aging process is going by, you will need a urologist to improve the quality of your life. Thank you very much.
History. We in urology still strongly believe that these patients should get screened probably about age 40 or 45 with a PSA and a digital rectal exam.
African American men, we believe, should start screening at the age of 40. Again, there's